You can either mix randomly or you can choose who you want to network with. Also remember that there's a question and answer box where you can pose questions during the lectures. There's also one more thing I want you to know, and that is that you should not forget the virtual exposition areas, where you can go in and discuss with the exhibitors or just look at their materials. We strongly encourage you to do that. Please stay on during all the day. Choose the things you want to listen to more carefully, and stay on for the video session in the afternoon by the young as well. Very much welcome. I'll now leave the word to David Albert to introduce the next session. Welcome, David. Nice to see that you are in Marseille already.
Yeah, thank you, Anne, and welcome to everyone around the world joining us for this session on COVID. So we will talk first about the very obvious implications that COVID had for ENT surgeons. And to underline that, we'll look at some of the science of aerosols and how we can use that science to protect ourselves. We'll hear from some of the surgeons who were caught in centers, in cities where there was a high prevalence, who were really in the sort of eye of the storm and their experiences. And then really to prove that we are a global organization, we will hear from Hannah Burns in Australia, and many of you will have already joined her WhatsApp group, so she'll be discussing that. So during the session, you will be able to use the question and answer facility on the right-hand side of your screen. So you can post questions, we will answer them during the session, and if there's a question that you really want answered, you can give a thumbs up to it, and it's more likely to get answered. So now I'm going to hand over to Michael Kuo, and many of you will know him from his work in the European Exam Board, who's going to talk to us about the impact of COVID on ENT surgeons. So thank you very much, Michael.
Good morning. Thanks, Dave, for putting this program together and specifically for convening this session. I hope that as we come towards the end of the second wave of infection in most parts of the world, this will be a curiosity for what we've learned over the past year, rather than a knowledge which we'll need to fend off further waves of this disease. And the risks which I want to address are the risks to the child and the parent, and the risks to the pediatric otolaryngologist under those general topics. Of course, the risks are different in different parts of the world. There are major international differences in first dose vaccination, in cases in the last 24 hours. Certainly on 13th of February, Sweden recorded no cases. And in the entire pandemic, New Zealand has only recorded 25 deaths. Of course, that is 25 more than there should be. But for a population of 7 million, that is really not at all bad. I want to mention at the outset my friend Amjad Al-Harani, who was the first doctor to succumb to SARS-CoV-2. He was a brilliant pediatric otolaryngologist at Derby Children's Hospital and a friend of mine. Those who work or trained in Edmonton will remember him as a fellow there some years ago. As a subspecialty, we haven't done too badly. My colleague Kate Stevenson was involved in both the UK National Registry and the Yo-IFOS survey. This goes back to May of last year, when only 361 otolaryngologists were registered internationally with COVID infection. Of course, that number is much greater now. But the proportion of deaths and the proportion of deaths over the age of 55 have remained largely the same. And interestingly, they've identified as a source of infection clinical activity in over half the cases, while prolonged exposure to an infected colleague only accounted for perhaps 1 in 10 cases. But we recognize that the ratio of healthcare to public prevalence of SARS-CoV-2 is about 3 to 4 times. This is data from London and Birmingham and Oxford and Leicester around the middle of last year. And it is because of that increased prevalence and increased exposure that a number of public bodies drew up guidelines for the use of personal protective equipment in secondary care inpatient clinical settings. And this was drawn up initially, I think, because there was such a dramatic undersupply of N95 or FFP3 masks at the beginning of the pandemic. And we really needed some guidance as to how we can conserve this and how we can prioritize this to the use with aerosol generating procedures, which will be discussed in greater detail by Claire and Colin later on. But hopefully in most centers now, there is an abundance of FFP3 or N95 masks, visors, and so on. These will be discussed also later, but right on early in the pandemic, all our colleagues around the world shared their experience and their methods of reducing aerosol spread from rhinology, in airway surgery, and of course the spread of aerosol with the mastoid drill. Evan Probst published his method for draping for airway procedures, and that is available online to see. Of course, some of our patients have their own idea of PPE. It does make examinations somewhat more difficult when your patient is Spider-Man. I don't know if Spider-Man has innate immunity against SARS-CoV-2. It's been also a problem for audiology, not so much because of what you can wear and what you can't wear, but in fact, all audiology booths are almost by definition poorly ventilated areas. And although the rules regarding room air change have changed over the past year, there's still a minimum time between patients, which restricts the footfall in audiology booths and dramatically affects capacity for pediatric audiology. What happens when children get infected with SARS-CoV-2? This publication, going back also about 6 months or so, reported on nearly 8,000 children. But the important thing here is that a fifth of them are asymptomatic. A lot of hospitals, supermarkets, and so on are testing people's temperature. But actually, 1 in 5 children who are infected or infectious are completely asymptomatic. And this has dramatic implications for elective surgery. We are now quite clear about those who have symptoms, and the syndrome of pediatric multisystem inflammatory disorder has been defined well. There was some concern with the emergence of the new variant that more children will be affected or more severely affected, but this recent paper just from last week in the Lancet shows no significant change in disease severity in children who have been infected with a new variant. That's a bit of good news. Back in April 2020, Sanjay Parikh moderated a session called Pearls from the COVID Trenches. And if you look at the columns on the right, at the time, asymptomatic pre-surgery screening was not really a reality in any major center other than Seattle, who were really quick off the mark and testing all children who came through. And at the time, they showed about 2/3% were positive. My urological colleague, Liam McCarthy, has driven the asymptomatic children testing for both emergency admissions and elective admissions to the Children's Hospital. And these are the regulations or our operational procedure for testing on the left. And we've shown that about 3% of asymptomatic emergency admissions have tested positive, and only 2% have tested positive for elective admissions. He also made some phone calls, or his team made some phone calls in the 2 weeks post-op after discharge, and they showed that less than 1 in 400 were positive. What's the relevance of that? Well, we want to make sure that not only do healthcare professionals not pick up disease from the patient, but also patients do not have comorbidity resulting from having COVID infection during a long general anesthetic. This paper just recently published from Indonesia shows that they found SARS-CoV-2 genome in tonsil specimens 4 weeks, 3 to 4 weeks after the child tested negative on a nasopharyngeal swab. So does that suggest that we should delay surgery for up to 4 weeks? But then again, you do need to test them anyway, 48 hours, because they may have incubated again. So I think we just have to be sensible while we recognize that there is a risk, and we just try to mitigate that risk as much as we can. This is the thing that's worried a lot of people early on, and that's because the adult data from Wuhan showed that of all, and these are all adults, there has not been a publication on children. All adults who developed COVID-19 pneumonia shortly after surgery, as short as possible, not infected or not in an incubation period prior to surgery. But there's also been a lot of non-COVID morbidity. And the fear has been that many of us have changed our practice, largely due to capacity for seeing patients, and both the physician and the surgeon fear of aerosol, the way we handle asymmetric tonsil enlargement. There's been a clear delay in the presentation of inhaled foreign bodies because there's a fear that a coughing child has COVID. The worry about aerosol generating procedures has led to an extension of interval airway assessments and also decision making and airway intervention, which has not really been informed by long-term research, but by very much level 5 evidence in managing these patients. There's been a significant failure of primary care engagement, partly because most primary care consultations now are remote, and patients have come very early to emergency care for pediatric otolaryngology. And to try and prioritize surgery, the British Association for Pediatric Otolaryngology has drawn up a list of operations which should be done: 1A within 24 hours, 1B within a week, 2 within a month, 3 within 3 months, and 4 beyond 3 months. And this has been especially important during the 2 peaks when in children's hospitals which are co-located with adult hospitals, there's been a great need for releasing capacity to the adult side. Much has been made about the risk to children not going to school, and those who have been doubly hit are children with tracheostomies. And I want to thank Kath Doxey and Neil Bateman in Manchester, leading the National Tracheostomy Safety Project, in publishing guidelines and trying our best to make sure that children with tracheostomies are not discriminated against when children go back to school. Last but not least, we mustn't forget the trainees who really lost a whole year of training. And my colleague Mike Saunders in Bristol set up the BAPO podcast with a number of webinars at the beginning of the pandemic. Deepak Mehta in Houston has set up a big series on pediatric airway symposia, and there are many others out there which are available and free. But most of all, we just need to stay safe, and hopefully we'll get through.
So thank you, Michael, for that very comprehensive overview. And I think clearly we are going to continue to need to think about this for many years to come. Probably we'll never get back to quite the same practice that we had before. And to help us with that discussion, we're going to move now to Claire in Australia. She was our fellow and did a lot of good work on aerosols. She spent all her weekends in an empty theatre with mannequins producing aerosol and making measurements. So I will hand over now to Claire.
Hi, my name's Claire and I'm an ENT resident from South Australia. I recently completed a paediatric ENT fellowship with the team at Great Ormond Street in London, and I'd like to thank Dave Albert and the ESPO Organising Committee for the invitation to present some work that I did during my time there, looking at aerosol generation and dispersion in the operating theatre. Let's be clear, aerosols aren't new. They've been around us all day, every day, and particularly when we're at work. And they're a normal part of breath, along with droplets and other gas molecules. However, the COVID-19 pandemic has made us acutely aware of what is being washed over us, particularly when we're operating in the airway as paediatric otolaryngologists. So shortly after COVID-19 appeared in the literature, different organisations and authorities began to issue information and guidelines on what PPE should be used by different clinicians in different workspaces. But this really did not have a strong evidence base. And one of the key papers that informed this work arose from the SARS pandemic in 2012. And Trans paper identified that healthcare workers who were actively and repeatedly intubating patients with SARS was 6 times more likely than their colleagues to become infected. We extrapolate that thought to a microlaryngobronchoscopy, where we tent the patient's airway open and we keep them spontaneously breathing in a high gas flow environment. We end up with a very prolonged aerosol generating procedure. Early in the pandemic, the first patient at Great Ormond Street, the first paediatric patient admitted to Great Ormond Street with COVID-19 was a neonate who was unable to be intubated. There was no literature or reference base for us to use apart from the PPE guidelines. So we quickly published our thoughts and experiences in the aim of keeping our colleagues around the world safe. The key issue here is that there's no published data about children's airways and the aerosol that can be spread from them. We do know that children have a smaller overall lung volume, and we do know that anything dispersed from a paediatric patient is going to be diluted more quickly in the laminar theatre airflow than that of an adult patient. We're also working in a high flow gaseous environment with either a nasopharyngeal airway or a Thrive high flow oxygen circuit on the patient while we're working. In the first instance, we aim to actually just work out where aerosols were being distributed during airway procedures on children. We wanted to better understand who was at risk. Is it just the surgeon? Is it the scrub nurse? Is it the other circulating staff in the room? And what might we do to help minimise occupational exposure? We found some studies that looked at the way that medication escaped in these type of settings and the occupational exposure to healthcare workers. And we applied this idea with the help of many team members throughout Great Ormond Street. We worked alongside our simulation colleagues. We took some advice from one of our respiratory professors and worked closely with our anaesthetic colleagues because they were just as concerned about this situation as we were. And this is the model that we came up with: a spontaneously breathing child in the operating theatre with backlit aerosols being dispersed so we could see what was going on. Let me share with you a few of the videos that we produced. Here you can see the model set up, and using a laser light, you're able to see the aerosol, the saline aerosol coming out of the patient model, dispersed over 2 meters, and the quick dispersion along the laminar flow within the operating theatre. When we look at simple airway manoeuvres like jaw thrust, we can see that the patient's airway is effectively opened, and we can see the spill of aerosol out and over the operator performing the procedure. Simple interventions like using an effective seal with a mask during during a mask anaesthesia or pre-oxygenating the patient is effective in trapping aerosol. But when we look at microlaryngobronchoscopy, bronchoscopy, we can see that our fears were confirmed, and that the airways tented open, and you watch aerosol floating out over the operator's hands and up into the face. You can see here with the Lindholm the jets of aerosol shooting up right over where the operator would be. When we looked at nasendoscopy and modelled this not in the outpatient setting but also in the operating theatre, we could see aerosol washing over the operator, and we can see that the simple intervention of a surgical mask at least decreases the amount that the healthcare worker is exposed to. When we look at the effect of paralysing a patient to stop them spontaneously breathing, we can see that there is significantly less aerosol dispersed over the operator, right up to the time when the cuff is inflated on the tube. To make our model, I'll give you a quick idea. We're mimicking a spontaneously breathing 5-year-old. We attached an aesthetic machine as a set of lungs. We included aerosolized saline into the circuit and then used a dual source white light to help visualize the aerosol, as well as a green crosshatch laser for some of the workers you saw. The model had some strengths and limitations, and it was a safe way to start investigating this poorly understood topic in the middle of a pandemic. But the model is limited in that it's not physiologically completely normal. We're doing some work looking to quantify the amount of aerosol that's dispersed and using salbutamol as the marker of the expired air to quantify the amount of aerosol that leaves the patient and would be inhaled by a healthcare worker at that distance. We decided to use an operated distance of 45 centimetres and then a second marker of 2 metres from the patient to simulate our circulating staff. When we have a look around, some other groups have been doing work in the meantime. There are cadaveric studies in otology that identified that the microscope position and irrigation rates didn't alter the way that fluorescein was splattered when drilling a cadaveric temporal bone. Our rhinology colleagues performed similar studies using drills and microbriders with underlying fluorescein under the tissues, and looked at the distribution and found that the high-speed drill did in fact distribute quite a lot of particle, including aerosol. Cadaveric studies suggest that there's no significant dispersion during grommet insertion, which I don't think would surprise many of us. However, when drilling a mastoid, there's significant contamination in the field. Finally, some other studies have looked at indirect ways to assess aerosol dispersion. A key anaesthetic group here in the UK compared a cough baseline to establish particle spread and found that in fact intubation in a planned controlled setting with paralysis distributed little particle matter, and even extubation did not generate or disperse much aerosol, particularly when compared to a normal cough. The rhinologists did some drilling and microdebriding and found that the key individual in the operating theatre exposed was the surgeon, while the circulating staff, scrub and anaesthetic teams were not significantly in the firing line. The rhinologists also identified that high-speed drills dispersed particles, including aerosols, quite widely, and that microdebrider with an inbuilt suction did not do this as much. One single paper looking at children and live surgery identified that there was no increase in particle dispersion when grommets were inserted, and that this was likely to be a safe procedure. So in summary, there's very little work out there looking at aerosol dispersion in the operating theatre, but we hope that some of the videos help you get a better idea of what you're being exposed to and help back up what we all understand to be important, and that's our use of PPE at this time. And I'd like to thank our operating theatre aerosol research group who have been fantastic to work with, and I'm looking forward to our future collaborations. Thank you again for your time.
So thank you very much, Claire. So as always, it's amazing to put a year's worth of work into 10 minutes. I particularly like the elegance of using salbutamol as a marker, and I think that we will need to have some quantitative data on all the different techniques that we're going to use to protect ourselves. And we're going to move forward now to Colin Butler's talk. He's was our fellow, and he's now a locum consultant with us at Great Ormond Street, and he's going to talk about how we protect ourselves. Thank you, Colin.
Hello, my name is Colin Butler. I'm an ENT consultant at Great Ormond Street Hospital. I'd like to thank the ESPO organisers for inviting me to talk about reducing aerosols. And this is really a continuation on from Dr. Claire Brown-Felder's talk, who I've had the great pleasure to work with at Great Ormond Street. So looking at aerosols and how we can reduce exposure, we have to look at where it may come from. In ENT, the ways in which clinicians have reduced exposures have been really dictated by the environment, namely this is theatres or outpatients. So what are the circumstances where this might be happening? And as we've heard, a lot of focus has been towards airway-related procedures. In ENT, with an arsenal of various powered tools, including instruments that can drill, chomp, and vaporize, it is almost impossible not to encounter a degree of aerosol in most of the procedures that we do. The question has been how much is generated and how it occurs, and particularly in pediatric populations, the number of particles that can be generated. Just to give you some context, we've looked at particulates in the theatre environment. And when you take a patient for a MLB and perform a tracheostomy, this is the kind of particulate generation that can occur. We see a spike in particulates generated when we insert the Lindholm device. We also see a little spike in obviously inserting the tracheostomy. But equally, you can see spikes in particulate generation when moving a patient around theatre. Similarly, when you use powered instruments, such as a coblation device which can vaporize tissue, you can see particulate generation through the coblation of the tonsil itself. Interestingly, in all cases, the highest counts have always been surrounding the exhaust vents, which is possibly due to the funneling effect of particulates through these areas. But the previous observations obviously downplays the role of ventilation. And just to show how important ventilation is, releasing particulates in a outpatient setting shows how these particles can hang around for quite a long time. And this is just shown here with the sub-1 micrometer particles in the outpatient department hang around for more than half an hour. So environment really matters. So how do we reduce aerosols? Well, there are broadly two main methods that we use. One is to create a physical barrier. The second is to remove particulates through extraction methods. Obviously, the most common and effective method used and still used is obviously with good PPE. In most countries, this would be considered a good face shield and goggles, an N95 or higher mask, and the use of gloves and an impervious gown. Obviously, there have been some variations to this, but the reason why other barrier techniques have been sought is because of the perceived risk with AGPs and the concerns related to equipment availability. The first areas to seek attention to this were through our anesthetic colleagues, who generated a whole load of devices related to airway procedures. And we can see how they created boxes and shields, which are essentially various tents and barrier devices. In the anesthetic world, the focus on intubation and extubation has generated more than 50 articles that have shown different permutations of barrier techniques. There's very little data on approaches for pediatric patients. ENT has obviously led the way in a variety of barrier methods. Our rhinology colleagues have shown adaptive barriers for sinus procedures and included adapting masks with valves, as shown by our Mass Eye ear team on the left-hand side, and from a team in Atlanta using 3D printed face masks. Barriers for otology include generating drapes that cover the operating field. And barriers for laryngoscopy include those similar drapes, but encompassing the whole patient. Our colleagues over in Toronto 6 Kids, CHOP Boston Children's, and the University of Colorado have generated a nice approach and consensus on how they approach patients for airway procedures. The problem with controversy, the problem with barriers are related to how much protection they offer, and we can see how they protect from larger particulates, but it's unclear whether they offer protection against smaller particulates. And there have been main concerns of also around limiting access, particularly around emergency airway procedures. The imperfections of containment as highlighted by this video, which shows that release of aerosol in these devices can still lead to escape, particularly around the operator. Even with the use of plastic draping, which directs it towards the feet, it's only with the large folded plastic draping that really contains around the patient that you see effective containment of aerosols. This is reflected by our own experience, where we looked at quantification through salbutamol assays, through a variety of distances from the patient themselves, showing that the barrier only offers protection close to the source, but not really further away. So can extraction methods help? Well, the short answer is probably yes. As you can see here, an Australian team at Fiona Stanley Hospital has shown how effective adequate extraction can be. They developed a method that uses theatre outflow tracts to extract air around the patient's airway. The high volume appears to be quite protective even during coughing. The only caveat is it requires connection to a hospital extraction system that's separate from standard laminar flow. Extraction methods have also been applied to rhinology barriers, such as face masks, using a negative pressure system. The issue has always been how to apply this through an MLB setting using suspension laryngoscopy. And as you can see that through these laser videos, that the aerosol can travel quite a fair distance in normal theatre settings. The extraction methods we have available include smoke extractions during suspension laryngoscopy. However, they often are very limited in how much they can extract. We wanted to develop our own scavenger extraction device, and this is something that we've worked on over the pandemic period. We've called it the Albert Scavenger, and as you can see, it borrows heavily from car exhaust systems, where it optimizes extraction. It's called the David Albert Scavenger after my senior colleague who conceived it on the back of an envelope and fits nicely on the end of the lint home. The extraction is quite effective visually, and when connecting it up to suction and comparing to the other suction devices available, it's quite effective at reducing exposure of aerosol. Similarly, quantifying it with salbutamol assays shows that it's quite effective at all distances. So we've seen how there are a variety of barriers are available and extraction, and it possibly is in combination with a barrier and extraction methods may be adequate in reducing aerosols. It's important to realize that aerosols do not equal infective load, and it's not a replacement for adequate PPE. Secondary aerosol generation is still unknown, but it's something that we're looking at. And I guess the question is whether we should continue using these as part of normal practice. And as this remains an unknown risk, we should continue to explore ways that we can reduce aerosols in the future. I'd like to thank the Operating Theatre Aerosol Research Group at Great Ormond Street, which includes Claire Frauenfelder, Annie Hall, and David Albert. And I'd like to thank my respiratory colleagues, particularly Professor Chris O'Callaghan, who has allowed us access to his lab. Many thanks.
Thank you very much, Colin. Once again, a lot of work went into that. And I think that we'll probably have changes in our practice which will continue beyond all of this pandemic, rather like after CJD, we gave up on non-disposable burrs for mastoids and things. Currently, we've got about 200 people around the world listening in, which is great. Do keep the questions coming. There will be time for conventional questions at the end, but it's quite useful to have them as we go along. I'm going to now hand over to Neil Bateman, who works in Manchester, and he's going to introduce some speakers from around the world and tell us what it was like in these hotspots. So thank you very much, Neil.
Thanks, Dave, and welcome everyone. We've got 4 speakers from various parts of the world that were identified as hotspots, just to share some of their takeaways and the highlights, if you can call them highlights, the lowlights of their experiences possibly. And we're going to start off, I'm in the unusual position of introducing myself as a speaker. We'll start off with my experiences working in Manchester in the northwest of England. So if we could have my video, that would be fantastic. Hi, my name's Neil Bateman. I work in Manchester, which is in the northwest of England. I work at the Royal Manchester Children's Hospital, which is a specialist children's hospital in the centre of Manchester. Of the 2 main issues that affected paediatric ENT care in Manchester and in the rest of the north of England, I really wanted to focus been accelerated by the demands of COVID. So as a consequence of the huge number of incredibly sick adult patients arriving in the adult hospital, our adjoining adult hospital, we lost all of our pediatric intensive care unit, which had to be rehoused on our smaller pediatric high dependency unit. We lost almost all of our operating capacity. And this just had a massive impact on our normal practice. For months, we were doing only life-saving or limb-saving surgery, which meant that we had to make rapid changes to our practice. And many of these are things that we have thought about for years or even proposed for years and had various obstacles put in our way. And almost without exception, those obstacles disappeared within weeks or even days. And it was the real necessity of needing to get moving because of COVID that really accelerated these changes. So just by way of some example, I'm sure everyone has adopted telemedicine, but this has been revolutionary in terms of just getting things moving in our practice. And while it's not I would never suggest that it's an alternative to actually seeing and examining patients, it's really useful in providing a really good service, especially when patients have to drive several hours to get to the hospital. For day case procedures, we've adopted a walk-in, walk-out service where patients just walk into the operating suite, sit in a reception area, and then are discharged home from recovery. And that means we're not dependent on whether or not there are beds in the hospital or beds on our short stay ward. And my frequent flyers, my papilloma patients absolutely love this new way of doing it. It's meant that we're much smoother in terms of dealing with flow through the hospital. We've had satellite operating units in the past, but they've never really worked particularly well. And this was just a great opportunity to get one of our particular satellite operating units, which we put in as a mobile operating theatre in a separate hospital, really working well. So we were able to run it as a completely COVID-free green unit and do day case surgery there, which was been fantastic, and would have taken months to get that up and running well had it not been COVID, had we not been in the middle of a pandemic. The other thing that's been interesting working in the context of the NHS and in the UK is there's been a big drive, quite reasonably, to ensure equity of access, to surgical care, so that patients are not disadvantaged by which hospital they're being treated on and where they're being treated. And what this has meant is that there's been a real drive for consistent prioritization of procedures and conditions, which has been really useful. And across the Northwest has meant a really big increase in network working, so that we can make sure that some of our hospitals in the Northwest have, some of our non-specialist hospitals have actually not started doing any pediatric work yet. And it's really important that children on their waiting lists are not disadvantaged because they're just not doing any of the surgery. So now we're in a point where we are generating a single waiting list for Greater Manchester, so that no children are disadvantaged in terms of where they're intended to be treated. So it's meant that our collaboration across the region has increased and is really likely to continue to increase over the next few months. So those are my takeaways that have been actually accelerated by COVID, and so I'd like to leave this on an optimistic note. Thank you very much. So we now move from the northwest of England to the northeast of the US, and we move to Scott Rickert, who works in New York on Manhattan, and they were obviously in very the effects of COVID-19 in New York was very well publicized, and they were very hard hit in a relatively early part of the pandemic. And so I'm really looking forward to hearing what Scott has to say about how they managed and what their takeaways were. So Scott.
Hi there, I'm Scott Rickert. I'm the Chief of Pediatric Otolaryngology at NYU Langone and Bellevue Hospital in New York City. And I want to thank the ESPO committee for having me on to talk about New York City during COVID. So if you look at New York City during COVID, you can see that we really had quite a peak starting in March 1st all the way to mid-May, and then it petered down until it became winter again, where it's now spiked all across the United States. Now, our timeline was really, our first COVID case was March 1st, and then it was March 7th, 8th, where we had a state of emergency declared, and New York City was issued guidelines to avoid densely packed buses, subways, and trains. And you can see a picture on March 9th. Clearly, people have listened. There's no social distancing, no masking, and obviously a lot of people on the subway. That was when we had 15 confirmed cases. A couple of days later, Broadway shut down, and we had a national state of emergency. And the first 2 deaths of COVID-19 were found in New York State. The public schools shortly after closed, along with the bars and restaurants, except for delivery. And on March 31st, we had 1,000 COVID deaths in New York City. So the goal was to try and really get people to stay home because we were very concerned about how quickly this was spreading. And if you look at the cases from February 29th to June 1st, there was over 200,000 COVID cases with 54,000 hospitalized and 18,000 deaths. So the daily caseload was about 5,000 by March 29th. With a daily hospital admission rate of 1,500 around that time. There was a 65% positivity testing at that point. So clearly everyone who was getting sick at that point was getting COVID. There was an overwhelming number of patients hospitalized within the city hospital system, and 25% of the COVID cases in April were from New York City. So we had field hospitals set up to help take on the burden. And there was a big hospital set up in Central Park, as you can see on the lower left, and on the lower right was the Javits Convention Center, which is meant as a field hospital. There were also centers set up in the other boroughs of New York, including the Bronx, Brooklyn, Queens, and Staten Island. The communities that were worst hit were really the densely populated areas of Queens, Bronx, and Brooklyn, and Elmhurst Hospital was sort of at the center of the Queens epidemic. And in April, 21% of the Queens neighborhoods there were COVID positive, with 60% of them having antibodies later on. So there was a lot of subclinical COVID happening as well. On May 5th, there was a survey done. 42% knew someone who was COVID positive, and 21% knew someone who died from COVID. So pretty awful numbers. The challenges from our end really were trying to preserve personal protection equipment. And we had a rule that we could have 1 N95 mask in my hospital system per week from March through the end of June. We were able to get regular masks, but the N95s were really in short supply. Some hospitals were stocked better than others, and fortunately, we had a lot of people from around the country sending us supplies. We also had a nursing shortage, so attendings, residents, and graduate students were being pulled onto the wards. I was part of the airway team, so we specialized in airway and intubation. So we did emergent intubations that were in the ER, the ICU, the floors. We also did all of the COVID positive trachs and the bronchoscopies afterwards to try and keep these people healthy. There's also an issue that people were dying at such a fast clip that the morgues were unable to process the bodies fast enough. So we had refrigerated trucks outside. You can see a few of them sitting outside my Bellevue Hospital right there on the right. So just to give you a sense of the social distancing and the quarantining, the pictures on the left are early April, where really there was no one out. And by mid-April, you can see that there were a few people out, but they're pretty socially distant. So New York City actually listened to what was being told. Now, as the timeline extended down, really, we extended our stay at home all the way to June 13th. It required face masks only in April, although it was recommended, but it was a requirement only in mid-April. So I wish that had happened sooner. And really, by the end of June, we had phase 1 was reopening, and July 24th, there was 227,000 COVID cases and 23,000 deaths. So that was all the way, through this pandemic. The challenge for us was to create a new normal. So we needed the PPE for the office, and we had HEPA filtration systems installed for every office to try and help with filtering the systems. In March and April, it really was just quarantined emergency surgeries only, and we did negative pressure rooms for COVID unknown emergencies. In May and June, we had a limited office schedule with elective surgeries only okay if they couldn't be postponed. And once it hit July, we still had our full elective surgery, new office schedule, which was fully functional, a little distanced, but fully functional. And we only allowed one parent to come with the child. whether it was office or hospital, and masks were mandatory for anyone 2 years and up. And the challenge was creating processes that kept patients, clinicians, and staff safe. There were also challenges in convincing families of a safe environment for the office or the OR. They really didn't want to come in if they didn't feel like they were safe. And there were challenges in not delaying necessary surgeries because they were scared of COVID. So they were more worried about getting COVID than they worried about a necessary surgery. The other side of it is that children were quarantining and social distancing and masking, so they were being more healthy than before. So there was a challenge in volume in cases due to that. So there was sort of a balance that the small elective cases weren't happening because the kids were healthy enough, but the necessary surgeries were trying to get them through. We had to convince people that they were safe. So one of the last things just to finish up is people always felt that New York City was dead after this. There was a lot of controversy about this. And Jerry Seinfeld said something to the point that Manhattan is an island off the coast of America. Are we part of the United States? Well, kind of. But one thing was for sure, we don't need someone in the thick of it wailing and whimpering, I want 2019 back. And we're going to keep this going with New York City, if that's all right with you, because all of the real tough New Yorkers who, unlike you, loved it, understood it, stayed, and rebuilt it. That sort of gets the heart of what New York is. There's a certain grit here, a certain resilience that comes through in New Yorkers that we're going to make it through. And so I hope that once we get a little bit safer, a little more vaccinated, I invite people over to come to New York and visit and discover what the tough, real New York.
Fantastic, Scott. Thank you. That's really, really interesting and really sobering seeing trucks for the bodies because the morgues were full. And no doubt that many of us will want to take you up on your invitation to visit New York because it really is a fabulous city. Next up, I think we'll all remember, certainly everyone in the UK will remember the north of Italy because there's the sort of wave of the pandemic hit the north of Italy before it hit the UK, and seeing pictures from there. And next up we have Alberto Sebene from Milan to share his views and experience from dealing with COVID from over there. So thank you, Alberto.
Good morning, everyone. It is a pleasure to be part of this ESPO conference. So I'm thanking the organizing committee for allowing me to be here today. And I'm also greeting you all on behalf of my chief, Professor Giovanni Felizat, who wasn't able to be here today in person, so he delegated me and I'm honored by this choice. My name is Alberto Sebene, and I work at the Santi Paolo Carlo Hospital in Milan, which is part of the University of Milan. As most of you know, Italy and the Milan area, more specifically, was the first European country to be held hostage by the COVID-19 pandemic. Exactly 1 year ago, we didn't know what we were dealing with. And most of all, we didn't expect that this situation would last a year and longer. What we had to do was to react quickly and proportionately and adapt and evolve. We choose to protect patients. We choose to protect the healthcare personnel. And for this choice, we follow one single principle. And every one of us and every patient could be a pouchy symptomatic or a symptomatic carrier of the disease. So we have to protect all the personnel all the time. The instructions we followed and that we are still following today were to wear N95 masks and protection goggles during all procedures, no matter if we were expecting to generate aerosols or if we were just dealing with earwax removal. So we protected ourselves all the time. We tried to make this choice as natural as possible for us and for the patient. And the higher level of protection was imposed to us as a measure to make everyone more comfortable. So what we reached in these days and what we are still doing today was to be able to deal with the patient almost normally. I mean, I know that PPE are uncomfortable. Most of the time they are cumbersome. But if you get used to it and you get used to your goggles and you get used to your N95 mask, you're able to approach even the pediatric patient naturally. So they don't get even more scared than what they already are when dealing with a practitioner. And you look no different, and your feeling is no different than what it was in 2019, for example. While protecting healthcare personnel and patients from the infection remains the most important rule still nowadays, there's another huge problem that gets bigger every day as the pandemic continues. The care of our pediatric ENT patients. So somehow, while we wait for this pandemic to be over, while we wait for hopefully the vaccines to be effective in getting rid of this pandemic, we still have to use general COVID-19 testing for elective surgeries. We still have to protect patients and healthcare personnel with the same PPI we use until now. And somehow we have to maximize exploiting the available healthcare resources in order to respond to the increased healthcare burden imposed by the COVID-19 pandemic, while still being able to respond to the healthcare demand of our little patients. Thank you for allowing me to report our experience from Milan.
Alberto, thank you very much. That was really interesting to hear how COVID has impacted hospitals in the north of Italy. So we've heard from 2 centers in Europe, from a center in the US, and now we move to Israel, and our colleague and friend Ari Duro to hear his highlights and takeaways from how the COVID pandemic impacted practice over there. So, Ari.
Hi, my name is Ari Duro. I'm from the Pediatric Otolaryngology Unit in Dana Duet Children's Hospital in Tel Aviv. Surprisingly, I mean, who would have thought about this a year ago, that I am going to give a talk about COVID-19 in a virtual meeting of ESPO. I mean, who would have thought of that? But here I am, and I have a disclaimer. I'm not an expert in COVID-19, and I really hope not to become one. But unfortunately, we all have become experts. I cannot read 40-page guidelines, so I'll try to be as short as possible. And most of us, of course, are not on the front line. So this is not about how to treat COVID-19. It's more about how do we treat children with children in the era of COVID-19. Most of them don't really even have COVID-19. And my suggestions are basically my opinions. COVID-19 in children. Children have milder symptoms of COVID-19 infection and are often asymptomatic compared to adults. Most children are thought to be exposed to the virus from an adult at home. Although children can transmit the virus to others, the transmission rate is unclear, with younger children less likely to transmit compared to children over 10 years old. So children are less sick with COVID-19. So what is the actual risk to us? Also, what we've noticed in our practice is that social distancing has resulted in much less cases of acute infections. I mean, they're just not getting sick with other things, not otitis, not sinusitis. We're seeing much, much less cases and their sequelae. We also have had to close down a lot of our activities, especially our elective activities during peak periods of infection in our community. And this was to allow resources for the ICU. We also have to remember that it's not over yet, and we still have maybe a year or two that we'll have to deal with it, with the hope that not some crazy mutant strain will emerge and we'll have to keep going on like this. So how do we care for pediatric ENT children in this kind of environment? The main dilemma is our risk of contamination. We don't want to get sick. We don't want our personnel to get sick, but we also, these children need treatment, and we don't want avoidance of treatment. We want to make sure they get their treatment in a timely manner. So first, we have to reduce our risk. The mainstay of reduction of risk is personal protective equipment, and we all know what that is by now. We do in our hospital pre-procedure COVID testing for the child, and also sometimes for the parent, only one parent that accompanies the child, and we do for the parent if they come from an area in our country that is more what we call a red area. The game changer will be, of course, immunization. As in our hospital already, 90% of staff is immunized, and this is going to continue on into the community, and we'll probably see a reduction in risk as that goes on. The first risk that we have in surgery is regarding the intubation. We're in the room. I mean, we might not be necessarily the one that's doing the intubation, but there are things that should be considered. We have to be there, full PPE, maybe a glidoscope would be better for keeping your distance from the mouth. Use a cuff tube so there will be less of a leak. Consider paralyzing, but the real problem is an extubation. That's when the coughing and dispersion of the aerosolized particles. In surgery itself, you have to use your imagination. I mean, you know what you want to do. Try and avoid as much contact with aerosolized particles, and this we can do in many ways. One of the problems we notice with the PPE is the condensation that you can see on the visors and on your glasses. We try to avoid this by attaching the behind the visor to a tube that insufflates air, and this first of all avoids the condensation, but second of all it causes some kind of a positive pressure so that when you're breathing you're probably not going to get any aerosolized particles inside your PPE. In our literature there were some interesting things to consider, and one of them is a child may be sick with COVID-19, hospitalized, and if you see unilateral findings on the chest X-ray, you should consider bronchoscopy because there might be also a foreign body. So something to think about. And extra precautions will be needed to be taken if you take this COVID-19 positive child to bronchoscopy. Of course, we have a problem here as far as aerosolizing. This was one of the studies that came out in the beginning of the pandemic where you can see an elaborate setup to avoid aerosolization. However, in my opinion, this is way too elaborate. And the main reason is that you have to consider patient safety. And I'm not sure you can actually see on spontaneous ventilation chest movement for one, especially when all this becomes with condensation. And then also if something does go wrong, the access to the airway might not be so quick. So as we all know by now, that surgery in the COVID-19 era is not the same. And it requires preoperative evaluation to lower the risks, takes more time, more preparation, requires cooperation between teams, and also demands more resources. All I can hope is that the next ESPO conference we'll meet, not virtually, and we'll be able to go over the old times of the COVID-19 era. Thanks.
Thanks, Ari. And it's always nice to end on a note of optimism and hope. So as time is tight, I am going to hand back to Dave. Thank you.
Thank you. I think we have got time just to discuss two things which that presentation has brought up. One is to what extent people are changing their practice outside of the operating theatre with things like telemedicine. And the second question, which a number of people have brought up, is the effect into the future on waiting times. So I don't know, is Hannah there? I thought we could perhaps ask Hannah and Scott as being two ends of the spectrum, if you like, of COVID.
Thanks, Dave. Yeah. I'll start from our end down here in the South Pacific, where we've been exceptionally lucky because we've moved very hard and early with COVID and really have not seen the problems that the rest of the world have seen. But I suppose some big positives is that we now do a lot more telehealth. And that has huge implications in a country as large as ours and states as large as ours. Our children now no longer have to come and see us face to face. And that's a really big bonus, not just for us, but for the parents not having to travel and for cost. And we now have Medicare rebates associated with that. So that's huge. And I hope that's here to stay. We've all been healthy, which is great. And that's because, you know, if you're sick now, you stay home, you get a COVID test, you can't go back to work, even with a sniffle, unless you've had a COVID screen that's negative. And that's the same for patients. They don't come in to see us. They're not allowed even to the hospital if they're sick. And we still have screening on all our doors. So patients get checked on the way in and they get sent away if they're sick with an alternative plan made. Ironically, however, we've actually just gone into a bit of a deadlock because everyone stopped hand hygiene and socially distancing because we're so good down here, and our hospital's full. We've got no beds because we've actually had a bit of a resurgence of RSV and rhinovirus over the last 2 weeks. So there is a backlash when people stop doing the things that they've been doing for the last year. I think you do see an increase in infections again, which we're seeing just at the moment.
And on waiting times, because a lot of us around the world have got this huge backlog. Are you seeing that or not really?
Look, I wouldn't say caught up, but we're pretty good. We're pretty much back to, I think, where we would expect to be. Except now we have no beds, so I can't get anyone to pick them at the moment.
Scott,
yeah,
what's your view?
We've been fortunate that when everything hit, telemedicine group set up. So we were already doing a bit of telemedicine. It really translated to 100% telemedicine for those couple months. And then as the numbers went down and things opened up a little bit in New York, everyone was still masking and socially distancing. So people were feeling a bit more safe, and people really wanted to come into the office. That's what we found. And so telemedicine really petered out. It's now about 10% of our practice. We still use it. It's really helpful for the complex kids who have a tough time getting transport, especially in wintertime. So our aerodigestive patients, our trach patients, we can really coordinate care pretty nicely and get everyone on the same telemedicine visit. So the pulmonologist and myself at GI. But most people still want to come in and really want to have that face-to-face. And I'm not sure if it's their social distancing loneliness or actually that they just really want to see, in person and really it's hard to look at an ear on telemedicine. So that's how our practice is developed. The waiting time, it's been interesting because people really have stayed inside. New York is, a concentrated place. So there's not that many places you can go to get open space. So people have stayed inside for quite a bit of time. There's not been as many sick kids as we are. The virus is still trickling around, but no one comes in with much more than their chronic tonsillitis or an occasional runny nose. But the ear tubes, the grommets have really disappeared for the most part. So we've caught up for the most part. When people want to get in, we really have spaced out our days. We're staying a bit longer. We're getting a little bit earlier to try and make sure that they feel safe. So it's worked out okay, and it's starting to get busy the past couple months. But hopefully we can keep everyone safe and keep things, hopefully we're hoping it's going to tick up a bit and not have too much of a lag.
Thank you. We haven't got time to discuss it now, but I know that Anne Hermansen has done some work, as I have, using parent held video otoscopes and you can get really quite good images. So maybe in the November ESPO we can have a little session on exactly how far we've got with telemedicine. Thank you very much, Neil, for excellent session. We're going to now have our final session from Hannah, who's going to talk to us about her WhatsApp group, which many of you will have been part of. And it was so useful, right? Thoughts and exchanging actual research papers. And it's really moved on from there now so that people use it for clinical discussion. So Hannah, thank you very much. If you'd like to.
Thank you, Mr. Albert and the organising committee for inviting me to be part of the virtual ESPO. I'd like to start by apologising to anyone who wasn't invited to the WhatsApp group this year. If you're still interested, please don't hesitate to reach out so I can add you to our network. Secondly, I've assumed that anyone who shared with the group over the year would be happy for me to share with this wider audience, excluding, of course, patient details. March 20th, 2020, I sent out a message to a small number of colleagues on my contact list. Here in Australia, we're just starting to see a few community cases, and it was uncertain what as paediatric otolaryngologists we could be doing to protect ourselves and our patients. Within 6 minutes, I had a reply from Seattle. What started as those just in my contact group has grown to a group of 169 paediatric otolaryngologists throughout the world. So I thought I'd take us through some of what we learned as a collegiate group, using this platform, discuss the pros, some cons, and share some memories. Early discussions brought to light concerns about our own safety, highlighted by the high infectious rates amongst ENT surgeons, first in Wuhan and then in Italy and other parts of the world. This risk of aerosolization was not lost amongst any of us. And so it's not surprising that those early talks really revolved a lot around PPE. During that first wave, there was a shortage of PPE, and so we talked reuse as well as alternatives. Globally, not everyone had N95 masks available. In India, they were using UV fridges to disinfect their masks for reuse. Some shared made-at-home versions, and 3D printers all of a sudden started printing face shields and filters. What to wear both in the clinic and in theatre and in what circumstances was discussed for days on end. And over time, people shared their protocols. Many had first-hand experience of wearing high-level PPE and the discomfort that caused with poor communication and the difficulties of doffing. Fit testing was, and in some places has continued to be erratic if available at all. And I think many of us have adopted the American style of wearing our scrubs all day at work, and our infectious diseases are finally happy because we're bare below the elbow. By mid-March, most of us were using telehealth and theatres have been limited to urgent. But these restrictions really only often brought about because physicians like us on the front line agitated for change. In light of the PPE shortages and the difficulty getting tested, we explored ways to improve our protection while performing aerosolizing operations. Although even trying to determine what was an aerosolizing operation was difficult. Early on, we just talked about tonsillectomy. I don't think we came to a consensus about what was the least aerosolizing technique for tonsillectomy. A variety of plastic drapes were proposed and practiced both in simulation and then in the real life scenario. And much of what we discussed was quickly assimilated into publications. It'll be interesting to hear how many are still using these type of techniques. We talked OR ventilation, and it was fascinating to hear the variability and the time taken to change the air within the theatre globally. As the year went by, pre-testing did become available, but we all know that this isn't the silver bullet, and PPE continues to be our best defence against this disease. Other protective measures were also shared, and who will forget Dan Tweedy douching out his nose with betadine. We also shared innovative ways to perform nasal endoscopy to reduce aerosolization. Marlene Soma from Sydney shared suggestions about keeping our families safe, and within days this had become an infographic. Many in the group shared having split teams before publication. Probably never before we had so much new information and shared it so quickly. You asked some preparation for what was to come, and also the opportunity for our colleagues to debrief and hopefully feel supported. We discussed paediatric specific presentations and were relieved when it became clear that children were less likely to get severe disease, but as the numbers climbed, there were always exceptions to this rule. Children, however, continued to have obstructive sleep apnea, stride or inhaled foreign bodies, so alternative treatment options were discussed along with what was deemed urgent and what could wait. Babies kept being born and even exit procedures had to be planned for, and we took our hats off to those who calmly managed these scenarios. Many of us also had adult roles, so we were able to share experience from the adult world. And this became increasingly useful as PICUs became full of adult patients and staff were deployed to adult facilities. Many of the group were also part of their own hospitals' tracheostomy teams. There was no shortage of meetings and learning opportunities this year. And I want to apologise to Great Ormond Street for the noisy Australians and New Zealanders who joined a grand round in April, many whom had not learned to that stage how to mute themselves or turn off their video. I hope we've all improved greatly over the course of the last 12 months. Although early on many of these talks were COVID related, as the year went on, the would-be face-to-face meetings were converted to virtual, and we were able to share links to get involved with these. Some in the group have had personal experience with COVID. In fact, our colleague Ravi was in hospital when I sent out the first message, and he was able to share his personal insights with us. Unfortunately, many others in the group have also had this opportunity as the year went on. And unfortunately, not all have recovered. We'll probably never know how many healthcare workers have died from COVID. Medscape, as of July 2020, listed 1,800 individuals from 64 countries, and we know that Italy alone had at least 77 doctors die. On the Medscape list, there were 20 otolaryngologists, and a study by the younger fellows of IFOS identified 24 in a paper they published in August. One of those was one of our own, one of our paediatric otolaryngologists from the UK, and we shared our condolences with both his family and his colleagues. But as equally important as the serious stuff has been the many jokes and silly stories that we've shared. We have laughed together, which has been good for everyone's mental health. And we can't forget the cyclists when we're ever at an ESPO meeting. We have celebrated Easter, Christmas, New Year together, and many other celebrations. As the year dragged on, we shifted our focus from the COVID specific to using the community as a brains trust. We discussed everything from difficult airways through to the best nasal endoscope. And although some of us have met face-to-face over the years, many of our colleagues haven't had that opportunity. So this platform has really had a levelling effect. It has broken down barriers of age, race, gender and geography. It has demonstrated the generosity of many experts we are lucky enough to call colleagues, and exemplified why diversity is so important. However, although these networks have the intentions of being positive, it's worth remembering there's a constant level of alertness, and this can lead to fatigue. ALOC reminded of this in March to us, and COVID fatigue has become a real entity, and we all need to remember to take some R&R and mute our conversations occasionally. So in summary, this group and other professional networks provide, I feel, many benefits. Those of us down here in Australia and New Zealand would like to say thank you for providing us with such useful advice early on. And I think this has helped keep us almost living normal lives down here in the South Pacific. And on a personal note, I can now reach out to a large number of colleagues and ask for advice at any time, as can everyone else in the group. Although we might have laughed about it, it's wonderful to hear our colleagues are getting vaccinated. But it's not until there's access for all across the globe that we will be gathering again as a diverse society. We should be considering what we can do as individuals and as societies to improve access for our colleagues and their patients across the globe. And I challenge ESPO and its members to really lobby our world leaders to make this a priority. So the virtual world is great, but nothing can replace face-to-face interactions. Although I think we can take away many lessons about communication this year, I look forward to being together with all of you in person when it's safe to sing, dance, laugh in Europe.
Thank you, Hannah. I think that that's very reflective, really, going through the timeline and just having some time out. And if you ever get depressed, just talk to Mike Saunders. He's always got a useful take on things. I think that we're probably getting to the stage now where we've had most of the questions during the session. And if I finish a little early, people can go and restock their coffee cups, or if you're down in the Southern Hemisphere, perhaps a gin and tonic, and get ready for the networking sessions. And thank you, Hannah, and the other sessions, the symposia that we've got over the lunch break. So thank everyone once again for all of your work putting this together, and we'll move on to the rest of the sessions now. Thank you very much.